very good evening and welcome everyone. I, Dr. Ritika Dhiman, on behalf of Voice of Healthcare, welcomes all the speakers and the viewers who have joined in for today's discussion. Voice of Healthcare, in association with Manipal Hospitals, has taken an initiative to bring together the experts and speakers for today's session on the unseen burden of hepatocellular carcinoma and current treatment options, which aims to know the signs, symptoms, and the new treatment options available for liver cancer. I would like to commence this session by introducing our eminent speakers. So, for today's discussion, we have Dr. Rajiv Lochan, lead consultant, HPB and liver transplantation surgery, Manipal Hospital, Yeshwanthpur and Sarjapur, Bengaluru. Welcome, Dr. Lochan.
Thank you.
Dr. 𝗚𝗏𝗧 Uthappa, consultant and head of interventional radiology, Manipal Hospital, Bengaluru. Welcome, Dr. Uthappa.
Thank you.
Dr. Amit Rauthan, HOD and consultant, medical oncology, Manipal Hospital, Old Airport Road, Bengaluru. Welcome, Dr. Rauthan.
Thank you.
Dr. Aparna Sreevatsa, consultant, medical oncologist, Nanjappa Healthcare, Karnataka. Welcome, Dr. Sreevatsa.
Thank you.
Along with sharing her views, Dr. Aparna Sreevatsa will also be moderating today's session. So without further delay, I would like Dr. Sreevatsa to lead this session. Over to you, ma'am.
Thank you, Dr. Ritika. I'm totally excited for this session today, that we have very eminent speakers and leaders in oncology like Dr. Rajiv Lochan sir, Dr. Amit Rauthan sir, Dr. Uthappa sir. So I think the patients will get a lot of insights about the important hepatocellular carcinoma. It is one of the top 10 cancers in India. And without further delay, I would like to start the question and answer sessions. And the first question is to Dr. Rajiv Lochan sir. So what do you think is the prevalence of hepatocellular carcinoma in India?
I think this is a great question. I think undoubtedly the numbers of this tumor are increasing day by day. We can see it in day-to-day practice and on discussion with seniors and and other colleagues. We know that the numbers are increasing. And one of the great things is that what we've seen, especially compared to work in the European countries, where both Dr. Uthappa and me have worked for a very long period of time, there's no screening program there. But this concept of master health checks and health screen is not really there, but which is there here in India. So there's a large number of people attending for asymptomatic ultrasounds and blood tests, and certainly numerous lesions in the liver are being picked up. So there are a few countries in which there is a screening program. I think we'll discuss about that later. So by and large, if you look at the numbers, in the Western population, the general quoted number is 10 to 15 per lakh population amongst men. HCC is predominantly a disease of men for various other reasons, which makes them predisposed to chronic liver disease. We know that HCC occurs on the background of chronic liver disease generally, by and large. And in women, it is kind of, half of that, around about 5 per lakh population. So that is the incidence. So the prevalence, which is the total number of cases existing at any particular point in time, that I'm really not sure that we have a correct number, for, India. There is some data coming out from TMH and from certain places. There was a big paper which came out from 𝗏𝗃𝗧 Hospital, written by, a colleague of ours, Professor 𝗏𝗃𝗧 𝗧𝗛𝗃, who was the HOD there. I think one of the largest numbers, I think they had around about 360 patients in 1 year presenting to a tertiary care hospital like 𝗏𝗃𝗧 Hospital. But that again, drains around about 11 to 15 districts of Karnataka. So the numbers we don't know, but I think GlobeScan reports that HCC is still the 4th largest for India. I think we all can accept that that it is a very prevalent cancer, because in a large number of people, and is responsible for a large number of deaths and a lot of patients present very late.
Yes, I totally agree with you, sir, that in India, we need our own registries, and the data collection is also not totally complete. And many of the patients in HCC, they don't get biopsy also. So there are patients who haven't got biopsy also. So the registries are also not giving us the entire picture. So I think we'll move on to the next question to Dr. Amit Rauthan sir. We are always talking about bridging the gap. There is always difference between urban and rural population. So when it comes to hepatocellular carcinoma prevalence, do you think there is any difference between urban and rural population, sir?
So I think that's a little, again, difficult to exactly say. Again, just as Dr. Rajiv previously said, it's very difficult to know what the prevalence exactly is. What we can definitely say is we are seeing much more hepatocellular carcinoma cases in practice, and this is in urban cities. We are definitely seeing a larger pool of patients. Now, we don't know whether it could be due to the etiology being different, the way the etiologies are various etiologies leading to CLDs, which group of patients are getting more. We are seeing a lot of NASH HCCs also now in clinical practice. Our hepatitis HCCs are actually not that high in number. I don't know. We may differ in this because of we see patients in different situations compared to what a gastroenterologist would see and then a medical oncologist would see. But we are definitely seeing HCC numbers have gone up hugely, and NASH definitely has been one of the predominant causes which has become the most important cause of HCC, which we are seeing going up.
So Dr. Rajiv Lochan sir said that screening programs are picking up many liver lesions. So maybe the difference between urban and rural population, maybe the rural lot may not be coming volunteering for health programs like screening programs. So where are we lacking? I mean, is that could that be a reason why we are seeing more cases, or what do you think, sir?
No, I don't think we are there in terms of screening yet. Though we say we should be there, we should be going aggressively in that approach, the way East Asia does, or that way. But we are not there. Definitely, we are not there. I don't think it's that screening is picking up more. I think it's the cause of HCC itself is different, and that's why you are seeing more of those patients with advanced HCCs. Now, we unfortunately in practice pick up very advanced HCCs, and that's what's different. We need to pick them up early, and I think that's what is very important to learn for. And I think we learn from Dr. Uthappa how to pick up early, and that's what should happen in practice, and that will change our behavior of our HCC patients.
Yes, I totally agree, sir. So the next question is to Dr. Uthappa, sir. So what are the common ways to diagnose hepatocellular carcinoma?
Thank you, Dr. Aparna. So basically, one point we're just about discussing about screening, and then we have a leading question to really how do you diagnose. Now, once there is a suspicion of HCC, so like we discussed, commonly we will have an ultrasound at some stage. Now, let's say it's part of a health check or part of some symptomatology. Commonly, patient goes for some non-specific symptoms to a gastroenterologist. As part of the screening, they will do an ultrasound. So we'd hope an ultrasound of the abdomen, specifically ultrasound of the liver, would pick up an abnormality in the liver. That itself doesn't say it's a HCC. That's more of a screening test, and we're going to pick that up. Obviously, as part of the screening, there will be blood tests done and some. Specifically, if there's a high suspicion of HCC with a background of liver disease, we'll be looking at some tumor markers. So once there's a suspicion, then we are going to, try and diagnose it. So the standard practice is either to do a CT scan or an MRI scan. And these scans have to be specifically tailor-made to the detection of HCC. Now, HCC or a hepatocellular carcinoma or liver cancer, for the common terminology, is somewhat unique because we have a lot of data and set guidelines which are recommended for as standards of practice. And they come with different terminology. And the more up-to-date is something called LIRADS, just from a medical term. So there really, we use a contrast-enhanced CT scan or a contrast-enhanced MRI scan. So that has to be tailor-made, preferably done at centers which are tuned to detecting these abnormalities and diagnosing it. So once we have a triple phase CT scan or a triple phase MRI scan of the liver, one can confidently diagnose a HCC in majority of the cases. And there are standard protocols that we follow, preferably a trained radiologist who is competent in reporting liver imaging per se. They will be able to diagnose the HCC. So largely, there are typical imaging features which we look at, and we'll be able to diagnose a hepatocellular carcinoma based on imaging alone, which would be either a CT or an MRI. And then there will be always the gray zone where the clinical parameters or the background liver disease or the tumor markers don't align with the imaging. And in those particular patients, we will proceed to requesting for a biopsy, a true cut biopsy of the lesion, usually targeted by ultrasound if possible in most cases. And that will help us to get a histopathological diagnosis. So yeah, so just one message, the hepatocellular carcinoma is a non-invasive imaging for diagnosis can be done. However, in the gray zone or equivocal imaging protocol that we follow, we will rely on a biopsy to diagnose a HCC. Thank you.
Thank you, sir. So the next question is for Dr. Rajiv Lochan, sir. Sir, what do you think are the risk factors associated with HCC in your patients with hepatocellular carcinoma? What are the risk factors that you usually come across?
Yeah, so I think this is again a very important question to address, because HCC is a tumor which develops in the presence of some pre-existing liver damage. I think this is something very important and to understand, and this is what makes it unique. And this is and this is why if you identify the people with the risk factors, then like Dr. Amit said and Dr. Uthappa said, if you identify the people with these risk factors, then you're able to identify the tumors themselves, at an early stage, so that you can actually cure them or at least try and treat them well. So there are basically 3 or 4, risks for HCC. One is, the biggest problem in India. Dr. Amit referred to it, which is NASH, which is basically what we all know as fatty liver disease. I think the unseen burden of hepatocellular carcinoma also correlates with the unseen epidemic of fatty liver disease, which we're now going through. Not an epidemic. It could even be a pandemic all across Asia, actually. So people are becoming more obese, and even people who are not obese are developing fatty liver disease. I think there's a very important message. So there's a study in the north of India where they looked at all blood donors, and more than 50% of male blood donors at 30 years of age who had a normal BMI, that's a normal BMI for India is around about 22 to 23, 50% of normal BMI males at 30 years of age had moderate steatosis. So people came to donate blood and they were all healthy, and then they went and they had an ultrasound scan. So there's a study done from AIIMS. So this was actually what drew the attention to the epidemic of fatty liver disease, which is now occurring in India. And with our food habits, increasing alcohol consumption, lack of exercise, and our propensity for sweets and high carbohydrate food, I think this is all becoming a heady mixture. So we're seeing fatty liver disease. I see a lot of liver transplant patients, and then a lot of living donors who come in, and half the number of living donors get rejected because we refer them to Dr. Uthappa, and then he does a scan and tells us that this person has got fat in the liver and cannot be a suitable liver donor. So this is the biggest risk factor in India, fat in the liver. The second one is obviously viruses, because viruses we know can cause liver disease. The common viruses are hepatitis B and hepatitis C. India has large pockets of hepatitis C and hepatitis B. In Karnataka, the north of Karnataka is a hotbed for Hep C and Hep B. We see numerous patients there, who have undiagnosed hepatitis C and hepatitis B, especially the Hep C people with diabetes at 45, 50 years of age presenting with multifocal HCCs. So Hep B, Hep C, this is another big risk factor. And then you have the chronic liver diseases of all other etiologies, which can actually also cause hepatitis C. So by and large, these are the few risk factors. And in the third group, I would put all the people who have liver disease because of excess alcohol drinking or because of any other metabolic factors. Children also can develop hepatocellular carcinoma, especially when they have metabolic liver disease. For example, a disease called tyrosinemia or glycogen storage disease. they can develop HCC in the teenage population as well, when they have some metabolic disease like PFIC and things. So this is the message which I want to say, is that if suppose somebody's got chronic liver disease of any reason, they are the highest at risk for developing HCC. And we talked about screening, and I think it is to this group of people that screening should be targeted. And Dr. Amit mentioned about the Far East, China. We measure ourselves up to China for lots of different reasons. Whether we like it or not. We want to make Bangalore like Shanghai and various things. They have a fantastic screening program for chronic liver disease. Anybody with cirrhosis gets an ultrasound scan and an AFP test every 6 months. I think that's something good to work towards in India.
Yes, but many patients, they get diagnosed with hepatocellular carcinoma first, and then they come to know that they have chronic liver disease also. So
Yes.
I think it's very tough. I feel this chronic hepatitis B and C are lucky that they get into the screening program and they get the ultrasound periodically. But these fatty liver people, we keep seeing so many ultrasounds, fatty liver, okay, it's nothing. But I think we have to be very vigorous. I think we have to sensitize the physicians and other healthcare practitioners that fatty liver isn't should not be considered like a very benign thing.
Yeah, if I can just add, Dr. Aparna, you're absolutely right there. Just want to add, fatty liver disease can cause hepatocellular carcinoma without causing cirrhosis. So it can actually cause a liver tumor without causing cirrhosis in the liver. So that's a very, very, very important thing, and we are seeing that more and more, in our practice now.
Yes, sir.
It's
So
not
the
benign.
next question is for Dr. Amit Rauthan, sir. So what are the common signs and symptoms associated with hepatocellular carcinoma?
Yeah. Just a quick completion of the last discussion which was going on. So one thing we'd like to reiterate is, the whole fact is, everyone does an ultrasound once or a scan once. The whole thing is, after that they don't do it further, and that's what we want to reiterate. That's if they are cirrhotic or all those high risk factors which Dr. Rajiv spoke about, they have to keep doing it every 6 months, and they have to keep being on follow up. That's what is screening. So the whole thing is, everyone is getting more and more aware. You'll see them do one good scan they will do at one time frame, and it may even be a good CT scan or triphasic scan. But then they will, after that, not come for follow up. They will think, oh, that scan is okay, so I'm okay, and that's where the whole problem lies. So that we'd like to reiterate that they should be on continuous follow up, and screening means keep doing it every 6 months, keep doing it every year. Don't stop doing it. Yeah. So anyway, you asked about symptoms.
The
Symptoms of HCC. The problem is this could be very vague. There's no one specific symptom you can say is for hepatocellular carcinoma. Unfortunately, most of these patients would be cirrhotic, and chronic liver disease would have led to HCC. So most of the symptoms would be related to the chronic liver disease. So it could be loss of weight, loss of appetite, being vaguely losing weight, becoming more and more fatigued. They could have pain in the abdomen. Those are the vague kind of symptoms which some of the patients present with. Those who present a little later present sometimes with jaundice, and even then there are those who present very late. They present with all signs of liver disease. You could have ascites, you could have edema, you could have high jaundice, and those are patients who really get sick and come to us in a very late stage. But most of the symptoms are quite vague. We do say, be aware if you have those symptoms of chronic liver disease. These are the ones you should keep looking for various signs and symptoms for HCC, but eventually do a radiological test, and that's the only way to take it further.
Yes, I think our healthcare system should promote more radiological infrastructure like an ultrasound in all the health centers and community centers. We usually have doctors, medicine, general medicine, surgeons are all there, but they don't have this radiology backup. So I think if our health system can strengthen the radiology part of the infrastructure, I think the moment they get some symptoms, they get a prompt scan, and they may be diagnosed at early stages also. At least they may get the diagnosis at the right time. So the next question is for Dr. Uthappa, sir. what are the treatment options available in India for HCC, sir? Let's make it more specific. What are the treatment options for early stages? Because you are into intervention radiology.
Yeah, so the treatment options is, it's extremely wide. Now, the patient's selection criteria for treatment really matters. And one point I'd like to reiterate here and probably stress upon is that the treatment planning for HCC is a multidisciplinary approach. What I mean is that experts of all kinds who are relevant to that treatment is very important, because that's where we feel from our own experience in multiple hospitals we have worked and at Manipal Hospital, it's a multidisciplinary approach. So I think that is one message. Then it really depends on the tumor characteristics or the liver cancer characteristics and also the background liver function. So that matters. And then also the patient's performance status. So we'll have to put all that into decision making for treatment planning. Now, specifically, when you say that for very early HCC, then obviously we're looking at definitely curative options, and that would matter with either the background liver is not good, then obviously we're looking at very early HCC. The options will come up as liver transplantation, or if patient is waiting for a liver transplantation or is unable to have a liver transplantation, then we can offer them a curative option like what is called ablation, which is basically burning the tumor and the adjacent part of the abnormal liver. And these are well tolerated by these patients. However, if the patient is presenting very early and the background liver is good, then they could have a straightforward liver resection. So all of these come under the curative options for very early HCC. So so it really, two things, size matters, particularly in HCC. And it also the location of the tumor matters, the background liver function matters, and the performance status matters. So, but definitely in very early HCC, we are looking at curative options, which would include liver transplantation, resection, and ablation. Probably just one more point, it may not be there in the guidelines. Sometimes we are unable to do all of this, and there could be a small tumor in a very critical location. Then one could actually also offer something called a radiation treatment. We have very advanced radiotherapy-based treatment with stereotactic body radiotherapy. With the modern technology, we can offer even SBRT for the small tumors, which may not be suitable for any of the other three which I just mentioned. So the treatment range is very vast. But again, the bottom line is it's got to be a multidisciplinary team approach for that particular individual. Yeah.
Yes, sir, absolutely. I think sometimes patients get confused that one doctor is saying something that they will do a resection. Other doctor says that maybe you go for a TACE or a radiological procedure. They get confused, and I think this is a message to all the patients and families. So doctors always consider what is the performance status. Is the patient able to handle the surgery? Will the patient benefit from the procedure that is done? And they are trying to offer you the best possible solution for the cancer, and they are looking at long-term cure for that particular patient. So Uthappa sir, would you like to share any success story of your patient so that patients they feel that hope about cure of early stage cancer?
Yeah, it just so happens. Thank you for asking the question. It's always nice to say success stories, but I mean, there is no single story that I want to really think. The success is really about detecting the tumor early and then approaching with what is best for the particular patient. But a very large number of patients. So I've personally been involved for the last 14 years with particularly with an interest in liver cancer, and I've worked with Dr. Amit and Dr. Rajiv extensively, and we have all of us contributed in the success stories of these patients. So an example could be, for example, a patient will present with a large tumor, which would be written off as a very large tumor. We can't offer a cure. In those particular patients, we put our heads together and then we approach it with a combined approach. Now, this could mean that we will shrink the tumor by either cutting the blood supply to the tumor or ablating the tumor, or sometimes the tumor is very large, but the rest of the liver, which the surgeon is going to leave behind, may be very small. So there we will offer a treatment called portal vein embolization. So what it means is we shrink the part of the liver where the tumor is, shrink the liver to say that we have something called contralateral hypertrophy. And then this patient, after 3 to 4 weeks, can undergo a very safe surgery with an outcome which will be almost 5 years survival of, 50% survival of 5 years, for example. And it is actually consistently in the last decade has gone further up. For example, I remember first time when we were talking about liver transplantation way back in 2008, that time I remember patients would come and say, success story is only 10%. But today we can say liver transplantation is 90% successful. Liver resection is almost 80 to 90% successful. And ablation is almost close to 95% successful. So by approaching with the best interest of the patient, we can actually increase the number of patients who can have curative outcomes. So there are many of these success stories that we can share. And the beauty is that there are many patients who were not suitable for curative surgery have now become suitable. And I think that's an important message, that if you work with teams and build a culture where we are able to refer these patients to centers of excellence, then definitely the outcomes will be extremely impressive. Even though we have a small number of patients who are suitable for it, but still we can get the best results for them. I hope that answers the question.
Yes, sir. Thank you so much, sir. And the same question for Dr. Rajiv Lochan, sir. Any early stage hepatocellular carcinoma you might have operated and the patient is doing well? Would you like to share any of your patient journey?
I think there is, there are a couple of patients who come to mind, who have survived for numerous years, and especially, one of them is continuing to do really, really well. But more than the ones who have undergone an operation, I'd like to mention one patient, a very elderly patient, who I think Dr. Uthappa will also remember, one of the very early patients that, we were involved in when I came back from the UK. An elderly gentleman from a very prominent family, numerous doctors in the family, had a lesion picked up on one of these health scans. This which I was talking about earlier. Health scans were not really popular in other parts of the world. So it's something called an annual health checkup, program which runs in most big hospitals. So this gentleman, was 80 plus, had the scan and then picked up a lesion. Then they came to us, and then we put our heads together, and Dr. Uthappa suggested an MRI scan. And we did an MRI, and it was a typically 𝗲𝗏 lesion. It was just about 2.5-3 centimeters in size. And there was a lot of discussion. It was in a very easily accessible part of the liver. And generally speaking, robotic surgery, laparoscopic surgery are very fancy words which are bandied around. And, they came to us, and then we suggested ablating the lesion. So the lesion was biopsied and ablated. And he did really well for like 5 to 6 years. He had a couple more ablations and then had a TACE as well. And it's somebody at 80 plus to have like a 4.5 year survival after treatment of a stage A, BCLC stage A tumor, I think is really fantastic. Yeah, of course there are operations. We're really happy about operations. And for resecting patients, in our surgical unit, we follow the HCC model, which is basically the Hong Kong liver cancer classification. If you classify patients with that type of cohorting, you're able to resect larger and larger tumors. Also, we are transplanting more number of early stage A and stage B even tumors. So this HCC classification allows you to resect multinodular, much larger tumors. For obviously in these, the liver should be able to withstand the stress, and there are a couple of ways in which we do it, like Dr. Uthappa was saying. There's another way in which we're able to assess the function of the tumor. We have a very fantastic nuclear medicine department, and Dr. Param actually counseled us against resecting a couple of patients over the past year, I remember, whereby you can do a mebrafenin scan and you can work out the functional capacity of the remnant liver. And that has stopped us from resecting patients. So yes, there are good examples of people who have lived long after resections, who also lived long after transplants. And we also remember patients where we didn't do the surgical operations for them based on good counsel from colleagues. This is also very, very important. And there is a new horizon, which is, I think, which is what Dr. Amit Rauthan and colleagues are doing nowadays. Maybe we are looking at downstaging HCCs and taking them for treatment, now, because see, testing the biology of of a cancer, is actually most important. And how to do it, I mean, we can do it all, statistically for 100 people, but that doesn't really apply to the one person sitting in front of you. And also we can do it statistically in the lab or in an animal model, but how are you going to do it in the individual patient who comes to you, in real life? So that's a big challenge. So and that has not been answered for HCC until now, I think. You really don't know the biology. You can do lots of things and you can prognosticate, but we all have been caught out. I've had a patient who had a transplant for a Milan and ended up with a recurrence in a retroperitoneal lymph node, and few months after transplant. He was actually a Milan, young chap, low FP. So I think, what I'm talking about is maybe downstaging with immunotherapy and then resecting them, ablating them, transplanting them. Maybe that's the new thing. So maybe we'll have to talk about that more, I think, because that's the new thing which is coming up. Because we're all agreed about transplant and ablation for early HCCs and, liver-specific radiotherapy and other newer, radiation included for stage C. Yeah. Okay.
Yes, it was nice to know about your patients and the strategy that you all used. So the next question is for Dr. Amit Rauthan. Sir, we always see patients in advanced stages and they get disheartened that they are not, maybe they're not for curative options like surgery or interventional radiological approaches. So for them, the last hope is you, the medical oncologist. So what are the novel treatment therapies that you are suggesting for advanced stage HCC?
Yeah. So as you said, unfortunately, that is how we see many patients of HCC in our clinical practice as medical oncologists. They are all advanced stage HCCs. They've either had TACE and then progressed, or after many years, or they are ineligible for all of these criteria. They are quite sick patients with advanced disease. But those patients, out of these, there are those patients whose liver function is still preserved, and these are the patients we can definitely offer all therapies which can prolong life, give them a good quality of life, and also sometimes we say do more exciting stuff. Now, earlier we used to see this advanced HCC patients, and we had only one tablet for these patients, and that was sorafenib. And for the last 14 years, we have been giving patients only sorafenib or supportive care. But it changed in the last 4 5 years ago when we got a new oral tablet, and that was lenvatinib. And lenvatinib did change our practice because it was much better tolerated than sorafenib. All our patients were able to do the ideal doses, and we started seeing our patients do better. So we looked at our own patient groups at our center, and we've seen our lenvatinib patient survival has dramatically gone up compared to what it was in the sorafenib era. Now, though if you look at data, the studies show non-inferiority, but we have already seen lenvatinib patients doing better than sorafenib. So that became our go-to regime. Now, also, the downstaging part was very exciting because we were involved in a couple of patients, and it was good to know because lenvatinib can give you response. And I still remember a couple of patients, I think Dr. Uthappa would remember them also, where we gave lenvatinib and the tumor shut down, which was so surprising, which never used to happen before in the sorafenib era. And then they did TACE on these patients. And there's some patients who survived so long after this kind of thing, which would never have happened in the previous era. So I think that's one group of drugs which is, yes, useful for us. But something in the last couple of years which is even more exciting is immunotherapy. And immunotherapy, we know in cancer has come up for every cancer in the body, but even HCC is leading the way because HCC first line therapy for advanced disease is an approval of immunotherapy in combination with bevacizumab. Now, uh, immunotherapy is exciting for all of us for various reasons. Even our patients love it, we love it because it's not chemo. You give chemo kills cells, kills normal cells, side effects happen, no patient is happy about it. But that's something that you have to keep coax your patient into chemotherapy. And we know in chemotherapy in HCC it never showed responses, does not work very well. Now with immunotherapy, it is unblocking our own immune system to fight cancer cells. And what we are seeing in our patients is there is a group of patients where the immune system becomes so active that it kills the cancer cells, and those cancer cells are kind of suppressed for a long time. So we call this the tail of the curve in immunotherapy, where you get long, durable responses, and that's what's very exciting of immunotherapy. So for advanced HCC, the recent approval is using an immunotherapy with combination with bevacizumab. That is one of the ways we are looking at. But there are many patients of cirrhosis who may not actually be eligible for bevacizumab because of portal hypertension and varices, they may have, which may be bleeding. So there is new immunotherapy combinations called the immuno combination, which has also got recently approved in the West. Unfortunately, the second immunotherapy is not yet launched in India. But now we have 2 immunotherapy approvals as first-line treatment for hepatocellular carcinoma. I, I think we have already seen a few patients with remarkable responses. The patients who responded so dramatically that the tumor just shrunk down, the scan showed that the uptake went off, and they're doing well for a long time. And this is something we had hardly seen happening in those advanced HCC patients. So we are very excited. Unfortunately, I always say that we don't have a biomarker for immunotherapy response. We don't know who will respond and who won't respond. And most patients who come to us always ask us, will I respond to treatment? And we have to tell them we can try our best with the best combination. If they get into a response, it can become a long-term durable response. But yes, there are patients who will not respond to treatment, and then one needs to switch to other lines of therapy. The good thing in HCC is there are recently, if I count, I think there are 9 new approvals totally for advanced HCC. And earlier we used to have just 1. So that's where the difference has come. In the last 5 years, 9 new regimes in various combinations, if I count them individually. So there are some things we can offer most of HCC patients, but yes, the patient's liver function needs to be preserved so that we can do these kind of treatments successfully. That's very important. And yes,
Thank
I cannot reiterate that fact. It has to be a multidisciplinary approach. I myself would say many years ago, we have also been very on the side that we used to think, oh no, this cannot be operated upon. Oh no, this is too big to do TACE upon. And we have learned over the last few years, there is nothing like us taking a judgment call. All of us have to sit together. It has to be a tumor board discussion. We have seen some excellent surgeries being done for tumors. We thought, as medical oncologists, they're not operable. But Dr. Rajiv and his team, they do amazing surgeries for such patients. I've seen big tumors being tased by Dr. Uthappa, amazing responses, and these patients doing well for a long time. So I would like to kind of emphasize it has to be a multidisciplinary tumor board approach. Every patient needs to be discussed by everyone, and that's the reason why downstaging will become even more prominent. You may give immuno in combination and reduce it and then operate it, which can be an amazing future for patients.
Yes, I think the multidisciplinary tumor board approach will also reassure the patient that all the doctors have sat together, they have discussed, and they are offering this as a staged procedure, that this is the whole treatment plan for you. So I think they will feel more empowered to undergo the treatment plan. So let's move on to the next question to Dr. Rajiv Lochan, sir. So what are the common challenges that you face while treating HCC patients?
I think it's a really practical question. I think one of the biggest problems is that people come late, or people present late. They come with very advanced disease, and very rarely do you have preserved liver function, which is because that's a very, very important aspect of treating these tumors. So you have and generally you end up having a combination of an advanced tumor and poor liver function. And if this is combined with the diagnosis having got delayed, or patients having gone around multiple places, which is actually the biggest challenge. I think there is of all the challenges, I think the most important one is that we do not have a standard referral pathway here in India, in our environment. I think that is the biggest challenge that I see, or having worked in one of the best healthcare systems, which we all, I think, would like to emulate. It is not because we don't have fantastic doctors. We have the best doctors, we have the best equipment, we can source the best drug here, in just a minute, which is, I mean the drug, for example, in one of the best countries in Europe, you will not be able to get the drug within, it will take you a few weeks for you to get approval for the drug. But here we can source it within a few hours. But unfortunately, the patients to whom we can give it are very few, because there's no standardized referral pathway. That's the biggest challenge. I think we somehow need to address this. The spirit of discussing patients together in a group is something that is very important, and especially as far as HCC is concerned. You need to have a medical oncologist, you need to have a gastroenterologist, hepatologist, you need to have a diagnostic radiologist, you need to have an interventional radiologist, and then of course you need to have a surgeon and various other supporting people as well, counselors and coordinators. So first of all, you need to have a scan, which is a good enough scan to diagnose. You need to have the right type of scan, and then you need to have the right type of tests, and people waste a lot of time, they will come into Manipal Hospital with a CD, or they'll come into Manipal Hospital more commonly with a report, and it will be a plain scan, or it will be an ultrasound, and some blood test. There'll not be a PT there, there won't be a CBC there, there won't be a full LFT, or they'll come in with a CT film, and then you won't have the CD, and then we'll have to tell them, see, you need to have a scan done, and they're sitting there wondering, yeah, I had a scan, in 𝗡𝗏𝗃𝗏, and Dr. Rajiv is asking for another scan. And then there is the cost, and then there's the time. So these are the biggest challenges. See, I mean, and most of the things in HCC are known to all practitioners. There's nothing, and medicine is a science. You don't need to be really greatly intelligent to practice it. But unfortunately, you need to have a system. And I think the biggest system is that we don't have a system in India. We're trying to make one in our Manipal environment. So we have a standard. And so if, for example, I write, somebody's got a liver SOL, all I have to do is just to send it to the radiology department, and they will do the scan which is necessary. They will do a triple phase CT, or they'll do a triple phase MRI, or whatever is needed. They will select it. And even if I've selected the wrong test, they will call me back, and then they will say, Dr. Rajiv, is this what needs to be done? And then I say, please go ahead and do it, because or I just walk down the basement to the radiology department, interventional radiology department. They're next to one another, and just sit and talk to them, and then you'll know what scan should be done, and then they'll sort it out for you. And then they'll do the volumetry, and they'll tell you the LAI, and then they'll also tell you that, look, there are varices here, a little bit of ascites, maybe you need to look for this, that, and the other, and that solves a lot of problems, and then they'll say, maybe you want to do a plain CT scan of the chest as well, because I just looked up the lab report, because I'd asked for an AFP in the morning, I had not seen the AFP, and they pick up that the AFP is 2000, and they probably are suggesting to you that you need a CT chest and bone scan. I think this system is what is important, and I'm happy that I'm in a system where all these things can be done for the patient. Of course, you have all the other problems of late presentation, economics, making treatment affordable, and a lot of things are being done to help that, but those are there in all parts of the world. I hope this particular problem with the system can be improved here, and
Yes.
it is getting better. It's getting better, I must say.
The same question to Dr. Uthappa sir and Dr. Amit sir. So, Dr. Uthappa sir, what are the challenges that you face?
I think a lot of the challenges we have commonly shared, I think, between the three specialists who are here. So probably most of it is covered. I think timely referral is the biggest challenge. I think for me, I find that's quite painful sometimes. And the second challenge is we have a bad habit within our community for multiple reasons. I won't go into that. That they seek multiple opinions, second, third, fourth opinion, and that delays the treatment or diagnosis in some time and the treatment. I find that is a challenge. And, to be very honest, the finances are a big challenge because we don't have a proper funding system for these patients. And all of these treatments which we have spoken about are, relatively expensive, but not so in the interest of the patient, definitely not. But yeah, so not that insurance penetration is very poor, and therefore So that is the challenge sometimes. We want to do the best for the particular patient, but they may not be affordable, and that's quite painful. So yeah, so I think broadly it is lack of the referral pathways. The second is, patient seeking multiple opinions. Third is, lack of adequate funding for a large number of patients. Yeah.
Yes,
I
sir.
think I'm sure I missed something. Amit will
Yeah.
touch upon that.
Sir, would you like to add any of your inputs?
Uh, I think I think everything's been covered. I would definitely say having access to all the teams is very important, and that's something that all of us need to be very open to. For the best interest of our patients, we should learn to talk to each other very quickly, and that's a good thing. That's what we like about our setups, the way we work. All of us work in various setups, but we are friends with all of each other because we just need to. When we see the patient, we need a quick decision, and that's where we need to just talk to each other, a quick opinion, a quick decision making so that our patients don't suffer, we don't lose time, and we take quick decisions so that the patient can get the best of care at the most rapid time possible. So I think this is something that we are all learning to do better. And I've definitely seen the change over the last few years. We ourselves used to be a little slow initially. We always were hesitant initially, but now we are seeing that all of us think the same way. And that's the best thing. When we all think in the interest of the patient, all of us do things very rapidly, and we can give them the best of care. Um, Cost, of course, is a problem always at some level. That is an issue. We as medical oncologists, when we talk about immunotherapy as fancy therapies, they do play a major dent on the patient's budget. That there's no doubt about it. Especially when you don't know who's going to respond, who's not going to respond. So I keep thinking research has to move forward more and more in HCC to try to develop biomarkers, to try to say which HCC would respond for immunotherapy, which would not. And this is something that is definitely being looked at. There's a lot of studies going on trying to look at biomarkers. So I think that way we will be able to justify which treatment to give to which patient, and that probably will make it more rational. Thank you.
Yes, thanks a lot, sir. The next question is for Dr. Uthappa, sir. So, what are the complications that can occur in HCC if it is not treated early?
So, so the HCC, once diagnosed, if not treated, right? So the complication would mean one is local progression. So if there's a local progression of the tumor, they can obviously, determined by the biology of the tumor, they could rapidly grow. So we have seen patients who present with what we call the tumor rupture. As the tumor reaches the liver capsule, it can have, a trivial trauma can bleed, and sometimes that could be the mode of presentation. Patient comes with a bleed, drop in hemoglobin, severe pain. So that could be one of the complications. Sometimes this tumor can spread into the blood vessels adjacently. So some of them can go into the hepatic vein, and we have certainly seen some tumors which have gone into the right atrium as well, and that can present with a venous outflow problem from the liver with, again, pain. Very rarely we have seen some patients present with pulmonary embolism with tumor spread into the pulmonary arteries. If it goes into the portal vein, which often does, we see some patients who are quite stable cirrhosis, they go into something called portal hypertension. We have seen patients who have had varicose bleed. We have seen patients who have ascites, and sometimes very progressive portal vein thrombosis causing bowel ischemia and stuff. Then there is a possibility that some of them can impinge on the adjacent biliary ducts, which is basically the bile duct drainage in the liver, and that can sometimes present with the jaundice related, the obstructive jaundice symptoms. They can have a lot of itching, and sometimes they can have infection because of poor drainage biliary system, and that's something cholangitis. That can make them very sick. And then obviously any cancer in the body which is not adequately treated, there can metastasize into different body parts. So bone pain can come if they go into the bone. We have certainly seen some patients go into that, and that can be, again, will need palliative treatment. And overall life. So generally, if you have advanced HCC, the life expectancy is we're counting in few months. So, I'm hoping that we don't see more of these, and the message is to try and get to some form of treatment. Like I said, with the combination treatments, and especially with Dr. Amit's highlighted, there are so many drugs which are approved we can, of course, it could be a trial and error for the particular patient because we don't have the biomarkers, but still, majority of them, we could palliate them and improve the survival, at the same time maintaining a reasonable quality of life. So I think it's a balancing act that we'll have to do. Certainly, we would not want to see these complications, which I've just highlighted. Thank you.
Yes, sir. Thanks a lot, sir. The next and last question is for Dr. Rajiv Lochan, sir. Sir, are there any treatment options that provide long-term success or cure for HCC patients? What do you think is the role of liver transplantation in patients with HCC?
I think that's a fantastic question, and you're asking a surgeon that, and that to a liver surgeon. So, yeah, I mean, transplant oncology is something which is coming up of late, and I think it really began with transplants for HCC. So, if you look at early HCC and a transplant for early HCC, which is Milan, and maybe even slightly beyond Milan as well, is probably one of the longest and most durable forms of therapy. Of course, it all. I think the key, is there are different treatments which can actually provide cure in the oncological sense. That is, you're looking at a 5-year survival, a majority of patients crossing 5 years, so different types. And it depends upon the stage of the HCC and also the liver function and also the patient fitness and also most importantly, patient expectation. I think that's also very, very important. You've got to take all this into account. Dr. Uthappa mentioned a couple treatment options earlier on. Ablation is as effective as surgery for small lesions. Judicious resections, I think that's very important because the morbidity and mortality with liver resection in a cirrhotic is probably equal to that of a liver transplant actually. So you've got to think about it very carefully, very, very carefully. It's got to be done in a place where you have the necessary multidisciplinary expertise. It's just not enough if you only have a surgeon. Surgeon is only one small part of the team. So to do liver resections, so certainly liver resections can give you very extended periods of survival, tumor-free survival and sort of overall survival. So transplant obviously for the right patient, done at the right time. And the selection of the transplant is also important. Are you using a deceased donor graft or are you using a living donor graft? All of these can provide long-term survival that is measured in multiple years, and also meaning that the majority survive 5 years. And of late, the boundary is being pushed, and we have to be careful as to that we don't overstep it. And certainly, this is where understanding the tumor biology, understanding or at least developing a tumor marker or a biomarker which will help us prognosticate those patients, and also downstaging therapies. For example, transarterial radioembolization. There are a few patients who undergone transarterial radioembolization, and we've resected them after that, after demonstrating that they don't have extrahepatic disease. And also we have radiated a few patients, when they've had portal vein thrombus, tumor thrombus. We radiated them, demonstrated stability of disease, and then we transplanted them. So the boundaries are being pushed, and certainly, but obviously, that is where multiple people talking and making a decision for a patient is so much more important, especially when you're trying to push the boundary. So you always need a balancing voice, and I mean, HCC is such a I mean, it's not nice to call it disease wonderful, but it's such a fascinating disease where you have ablation on one end and you have transplantation on the other end, and then there are so much more newer things coming in, and we have systemic treatments coming in. So yeah, all these curative options which I've just mentioned, they're suitable only for a small number of patients. But I suspect that as days go by and as years go by, there will be lots more newer treatments which will enable more people to have these curative options, and that's something that we all look forward to.
Yes, sir. Thanks a lot, sir. So we had a very interesting discussion where all the different specialities, the specialists have shared their thoughts, and I hope that the patient treatment options become more and more affordable in the years to come, and maybe patients will get funding from the government or from their insurance and more importantly than the finances is the attitude of the patient to reach out to a center where multidisciplinary a team of specialists can cater to their problems. I think it was a wonderful discussion. A last message, one-liners from all the speakers. What is the message that you want to give to the patients who are diagnosed with HCC? We'll start with Rajiv Lochan, sir.
I think the most important thing which I'd like to say is that, the diagnosis of HCC doesn't mean that there's no treatments available. That's the general nihilistic attitude. There are lots of treatments available, and a lot of these treatments are evolving and new things are becoming available. So, hoping for the best and having a positive attitude always helps.
Yes, Amit, sir.
Yeah, we tell all HCC patients, don't lose hope. There are so many new ways by which we can treat their cancers, and there is ways by which, even if we don't cure them, we give them a good quality of life with elongated, prolonged survival, even in the advanced disease.
Thank you, sir. Uthappa, sir.
Yeah, just for one line, not to lose hope. I think hope is something you really hold on to, and be just open in the discussion and participate in the discussion.
Yes, sir.
There's just
Thanks.
one point. In the comment section, there is by one gentleman who's asked, are there any lifestyle changes that can help in reducing the risk factors of developing liver cancer? Maybe Rajiv can answer that because he sees these patients and some of the risk factors can be reversed.
Yeah, I think the most important thing I'd like to say to Shubham Gupta there is that, what is good for the heart is better for your liver. I think that's the message. So what I'd like to say, I think judicious eating, no sugar or low sugar, less carbohydrates, good exercise, moderate amount of alcohol. I think these are important things, very important.
Just one more point to add. One more point to add, extension of that. If you have viral load, a viral disease, don't lose hope. I think if you follow, like what Dr. Amit said, have regular screening, not just one scan, get your treatment, be under the care of a gastroenterologist or a hepatologist. Many of these cancers can be picked up very early. So I think, participating and with the doctor is very important.
Yes, and with the newer antiviral therapies that we are seeing today, the viral loads are under control and almost becoming zero with prolonged treatment. So I think that's the message that we have given, that everyone is very enthusiastic about the treatment options that are available today. And we are no longer afraid of the word cancer, and we are even giving cure to patients with hepatocellular carcinoma.
Thank you so much.